Hello, cohort 2027. We'll go ahead and get started with the next modules. For this lecture, I actually combined module J and K. On your syllabus, it had module K twice, but it should have been module J for cardiovascular system and module K for the vascular pathophysiology. So I've combined the two, and hopefully we'll get through these pretty quickly. So what I did for module J and K, altogether was about 25 instructional objectives. And because both of these modules kind of work intertwined and within each other, I combined the topics and was able to condense the instructional objectives down to about 10. And I'll still correlate the original instructive objective, and I'll show it to you on the slides when we go through so you'll know how to follow in your syllabus. So we're initially going to talk about cardiovascular anatomy and physiology, which will include the chambers, valves, vessels, and endothelium. We're going to talk about cardiac hemodynamics. We'll discuss cardiac output, preload, afterload, contractility, and systemic vascular resistance. We'll talk about the major cardiovascular diseases, such as coronary artery disease, heart failure, valvular disease, and hypertension. We'll talk about the mechanism, significance, and complications of some of the major arrhythmias. We'll discuss and explain the pathogenesis of atherosclerosis and discuss how it affects like coronary artery disease as well as peripheral vascular disease. We'll then briefly touch on thrombotic and embolotic disorders such as DVTs and PEs. We'll discuss the 4 types of shock: hypovolemic, distributive, cardiogenic, and obstructive. Talk a little bit more about peripheral vascular disease and how it can present with peripheral arterial disease, venous insufficiency, or a form of aneurysm or dissection. And then we'll talk about risk factors and prevention. And lastly, we'll briefly talk about cardiovascular infection. A lot of the infectious topics you will get more of in infectious disease. So let's get into it. So the first topic we will be discussing is cardiovascular anatomy and physiology. This correlates to Module J, Instructional Objective 1, and Module K, Instructional Learning Objective 1 and 2. So on this slide, I'm just going to be discussing briefly the different chambers of the heart, the valves, and blood flow. So over here, you can actually see this is the structure of the heart. Blood flow usually comes through the superior vena cava and the inferior vena cava that would be right here, and will enter into the right atrium. This is venous return, so it is blood that is higher in carbon dioxide than oxygen. So it goes through the right atrium, through the tricuspid valve into the right ventricle, which is down here. The right ventricle will pump the blood through the pulmonic valve, which is right here, um, to go into the pulmonary artery, which then will travel into the lungs to receive oxygenation. Then the blood will return via the pulmonary veins back into the left atrium. Then through the mitral valve, the blood will travel down into the left ventricle. The left ventricle will then push this blood through the aortic valve into the aorta, where it will go out into the system. And again, those heart valves, from the right atrium to the right ventricle, you have the tricuspid valve. It has 3 cusps. This is a top view of it, so you can actually see those 3 cusps. And its main job is to prevent blood flow during systole, and systole is a contraction. So when the atrium contracts, the blood goes through. The valve is to close so that you don't have any retroflow or retrograde flow of that blood. Then the blood again will travel from the right ventricle to the pulmonary artery, and it goes through the pulmonic valve, and you see that right here. It's a semi-lunar valve, and it opens with right ventricle contraction. Again, that blood goes it travels through the pulmonary arteries into the lungs, where it becomes oxygenated, and it returns to the left side of the heart via the pulmonary veins. And once it goes to the left atrium, it will then travel down to the left ventricle. It will travel through the bicuspids or the mitral valve. This is normally the most diseased valve that we see. And once it's in the left ventricle, once that ventricle contracts, it will then go through the aortic valve, which is right here, wrap around, go to the aorta, and let's go to the major organs and to the systemic system. It's also a semilunar valve, and this is the most common valve for stenosis in the elderly population. So I know this is just being redundant, but just wanted you to be able to see the flow of blood. Again, this is the superior vena cava, this is the inferior vena cava. Blood, deoxygenated blood, which is shown here in blue, comes in through the right atrium. You have a contraction, it's going to push it to the right ventricle through the tricuspid valve, and then that ventricle will contract and push it through the pulmonic valve and into the pulmonic arteries. Those arteries go to the right and left lungs. Then it returns again to the oxygenated blood at that point returns to the left atrium, travels through the mitral valve into the left ventricle. Then the ventricle will contract, push the blood through the aortic valve, again around into the systemic system through the aorta. Just of note, and I can remember this giving me some trouble. You always, normally you'll think that veins carry deoxygenated blood and arteries carry oxygenated blood. The one time that it's reversed is in the heart. So the pulmonary arteries actually carry um, the deoxygenated blood, whereas the pulmonary veins will carry the oxygenated blood. Okay, so gonna move on to the blood vessels. Um, so you have two main types again of blood vessels. You have the arteries, you have the veins. Um, of importance, you have the endothelium, which is this like inner portion of both of them. The endothelium is very important for like regulation of vascular tone. And then you do have these other areas. The endothelium is part of the tunica intima, and then you have the tunica media and the tunica externa. The arteries and the veins form their own kind of network, and you go from an artery to an arteriole, which is about right here, and then this little area is called a capillary network. This is where most of the blood receives it does the diffusion of the oxygen. So the capillary networks are normally in your tissue and your peripheral organs. But this system works together to make sure that you get the nutrients and the oxygen that's needed for your body to function appropriately. So just to go a little bit more detail into the endothelial function, and we'll touch base on how it also has an effect on blood pressure. Um, so the endothelial or the endothelium, it helps to regulate vascular tone. And like I showed you on the previous, it's like the innermost lining of the vessels. Different things can affect it, like nitric oxide can cause it to vasodilate, allowing for more blood flow to a particular area. And then endothelium can actually cause it to constrict when you're trying to prevent blood flow from going to a distal area. It can have some antithrombotic properties. It can produce prostacyclin or PG1/2, which will inhibit platelet aggregation and allow for vasodilation. So if it's inhibiting platelet aggregation, it's going to allow for increased blood flow. It can also release TPA, which promotes fibrinolysis, which is another way of just breaking down some of the clots. So it can again have the antithrombotic properties. It also acts as a barrier for transport. It controls the permeability between the bloodstreams and the tissues. It also has some inflammation and immune signaling. It can express adhesive molecules like VCAM1 and ICAM1, which will kind of help recruit leukocytes. And I'll show you a little cartoon of it a little bit later. This plays a very important role in the formation of or the pathogenesis of atherosclerosis. And then the endothelium is also very important for vascular remodeling. It responds to shear stress, pressure, and injury. So this is kind of a slide just summing up the last maybe 3 slides. So we have different blood vessels, the arteries, arterioles, the capillaries, and the veins. Again, you have different layers. So with arteries, the thick tunica media is comprised of smooth muscle and elastic fibers. It can tolerate higher pressures, and it helps to be a conduit to transport blood away from the heart. There are some elastic arteries like the aorta that are able to absorb more of the pressure, the systolic pressure. And then you have a muscular artery that helps to regulate the distribution of the blood. And with the arterioles, they are the primary resistant vessels. They help to control blood pressure via vasoconstriction and dilatation. They do have some local metabolites that regulate tone, and they are a key determinant of systemic vascular resistance, and we'll talk about that a little bit later. The capillaries, again, that is the site where you have your gas and nutrients exchanged in the tissues. It's usually a single endothelial cell layer. You can have transcapillary forces, where you have Starling's law, and we'll talk about Starling's law a little bit later as well. But it has to do with oncotic pressure versus the hydrostatic pressure, and where the pressure is, it kind of transfuse across. It will transfuse across. And then lastly, you have the veins. They can tolerate the lower pressure because they're low pressure capacity vessels. They usually hold around 70% of our total blood volume. Venous return normally is dependent upon the muscular pump as well as the valves that are within the veins. And incompetent valves, you will start seeing like some venous insufficiency. And we're going to talk about that like at the very end of the lecture, but that's where you'll start seeing like venous stasis changes, um, varicose veins, things like that. So again, the endothelial function, um, it can produce and be sensitive to nitric oxide, which allows for vasodilation, which will increase flow or increase pressure. They can also have the prostacyclin effect, which is an antithrombotic. It will prevent platelets. It can have the some vasoconstriction functionality, also some TPA, again, where it's going to prevent any type of clots. If there's any dysfunction in the endothelial function, whether it's due to injury or lifestyle that's causing an injury, that's usually where you start getting the first steps of atherosclerosis. And I'm going to have a slide that's going to go into a little bit more detail about that. Okay, next, we're going to jump into the topic of cardiac hemodynamics. This does correlate with instructional learning objective for J3, which is describe the mechanics of heart contraction and the factors affecting cardiac output. It also correlates with Module K, Instructional Learning Objective 2, which talks about explaining the mechanism of blood pressure regulation. So, cardiac output is actually the total volume of blood the heart pumps per minute. There is a formula that goes along with cardiac output, which is heart rate times stroke volume. And stroke volume is the amount of blood ejected by the left ventricle with each heartbeat. Normal cardiac output is around 4 to 8 liters per minute. It helps to determine global tissue perfusion. It is influenced by heart rate, contractility, preload, and afterload. And we'll get into a little bit more explanation of that shortly. With the stroke volume, it's normally between 60 and 100 mLs per beat. It is also regulated by 3 major physiologic factors, again, preload, afterload, and contractility. And then you'll also hear about cardiac index. It is a key hemodynamic parameter that evaluates heart function. So cardiac index is usually cardiac output over the body surface area. It is normally 2.5 to 4 liters per minute. But from this slide, I do want you guys to know cardiac output as well as stroke volume. So this slide will break down a little bit more of, preload, afterload, and then we have another slide that hopefully will give you a bigger picture. So we've already gone over the formula of cardiac output, which is heart rate plus stroke volume. However, cardiac output has some determinants that can actually change the cardiac output, increase it, decrease it. These determinants usually affect stroke volume, and that's how the stroke volume actually affects the cardiac output. So the stroke volume is, more sensitive to the preload, afterload, and the contractility, whereas the heart rate is a little bit more sensitive with the cardiac output. Okay, let's get into preload. So preload is also known as ventricular end diastolic volume. And it is filled by the venous return. So I'm going to show you a picture of it. So preload is affected on the right atrium. So it's the blood that is at the end of the diastolic volume that is returning back to the atrium. It is most affected by Frank Starling law, and that law simply states the more it is stretched, more there's going to be more force in the contraction up to a point, and then there's decompensation. So just simply put, if more blood enters the heart, like increase venous return to the right atrium, the heart stretches more and pumps out a greater volume of blood, trying to balance the input and output. So preload is increased by, and I just stated it, the volume overload. It can also be increased by regurgitation, meaning from the right atrium to the right ventricle, if blood has that retrograde flow, that is regurgitation. And if blood has that retrograde flow or the regurgitation, it's going to increase the volume in the right atrium, causes it to stretch, and then when it does contract, it's going to be a more forceful contraction. Now, preload can be affected negatively by dehydration, diuretics, as well as hemorrhaging. Now, afterload, it is the resistance that the ventricle must overcome to eject blood. So it's usually like the systemic vascular resistance on the left ventricle. So if you think about it, the preload is going to affect the right atrium because that's where blood is traveling in. The afterload is going to be affected or determined by the left ventricle because that's the final place where the blood is being pumped out to where it could go to the periphery, to the tissues and the main organs that need it. It can be increased. So this afterload can be increased by hypertension and aortic stenosis. And the aortic stenosis is because you will have increased force trying to push past that stenotic valve. And so that's how it can actually increase the afterload of the left ventricle. And it can be decreased by vasodilators such as ACE inhibitors or nitrites. If the afterload is increased, there's going to be an increase in wall tension, which results in an increase of oxygen demand, which will decrease the stroke volume. The next one is contractility. It's the intrinsic myocardial force, like how well the heart is able to contract. It is independent of preload and afterload. Contractility has nothing to do with preload and afterload. It can be increased by catecholamines, certain medications like digoxin, dobutamine, and calcium. It can be decreased by acidosis, hypoxia, an MI, beta blocker, or a calcium channel blocker. The contractility is usually measured as EF, or what we call ejection fraction, and normal is above 55%. And lastly, heart rate. This is usually determined through the SA node, which is in the right atrium. Normal is 60 to 100 beats per minute. This can be increased by fever, hyperthyroidism, anemia, pain. It can be decreased by the parasympathetic nervous system. And I'm sorry, SNS is sympathetic nervous system. But it can be decreased by the parasympathetic nervous system via the vagal, like a vagal maneuver. Also with beta blockers and heart block can affect heart rate. If you have a very high heart rate, 9 times out of 10 you're going to have decreased diastolic filling time. That's just the heart is pumping so quickly. You're probably not going to feel the area up as rapidly as needed. And this can lead to decreased cardiac output and can later lead to heart failure. So an example, atrial fibrillation that's not rate controlled. You have a very, very high heart rate. It will decrease some of the diastolic filling time, which in turn causes pretty much some collapse, and patients can develop heart failure from it. So, just a little, graph, a cartoon graph to show you there are 4 determinants of cardiac output. Heart rate is the one that is directly affected for heart rate. And then you have preload, afterload, and contractility that affects more so of the stroke volume. So again, heart rate affects cardio output directly. Preload can adjust the stroke volume due to the ventricular filling. Afterload determines resistance to ejection of the blood. So again, preload is on the atrium. Contractility is how well the heart is going to contract and pump. It will go through the pulmonary artery, go to lungs to be oxygenated, and then come back into the left atrium through the left ventricle, and then it's going to go back up here and go out the aorta. Well, afterload is usually on this side. I think that's all I need for that slide. Okay, on this slide, I just want to introduce some terms that we will talk about later in the lecture. However, preload and afterload can also be regulated, and usually these different things are terms that will be used to discuss the regulation of preload and afterload. So systemic vascular resistance is the resistance the left ventricle must overcome to eject blood. So this is mainly on the afterload. It reflects arterial tone and vasovascular constriction. It can be increased in hypovolemic and cardiogenic shock. And when we get to the different areas of shock, that's where we'll see these terms again. A lot of times I see these terms used in the ICU when you're trying to accurately measure the patient's hemodynamics status. The SVR can be decreased in disturbative shock. Another term is pulmonary capillary wedge pressure. It is a indirect measurement of the left arterial pressure, and and for left-sided preload. So again, it is an indirect measurement of left atrial pressure and left-sided preload. It can be increased in hypovolemic shock. It can also be increased in cardiogenic shock, and it's kind of variable in obstructive shock. And lastly, the central venous pressure. If any of you go into primary care in the hospital setting, if you're ever taking care of patients in the ICU, a lot of times they will have some type of measurement, some way to measure the central venous pressure directly. It reflects the right atrial pressure and venous return. It can be decreased in hypovolemic shock due to depleted volume. It can also be increased in obstructive shock. Okay, next I'm going to talk about the major cardiovascular diseases. And this correlates with Module J, Instructional Learning, Outcome 4, 6, and 7, Module K, Objectives 4, 7, and 8. So first, we're going to talk about some coronary artery disease, risk factors, pathophysiology, and diagnosis. So what happens in coronary artery disease is going to start off with the progression of atherosclerosis. And this process takes place when you have an endothelium injury, you have LDL oxygenation or oxidation in the bloodstream when you have elevation of the LDL lipids. This oxidation will trigger immune response, and in that immune response, a different cell is originated called the foam cell or the fatty streak cell. These cells are the ones that kind of migrate to the lining of the vessel, and they can initially cause a fibrous plaque. What happens, you come into problems, or the patient develops problem, is when this plaque ruptures. And when it ruptures, it sets off another cascade of events to where you get the clumping of platelets and blood cells, and you'll end up forming some form of a thrombus. This thrombus is what leads to acute coronary syndrome, which is ACS, also known as MI. So some modifiable risk factors, meaning things that can be modified to decrease the risk. One is hypertension. The second one is hyperlipidemia, especially with an elevated LDL, as well as a low HDL. Diabetes mellitus, insulin resistant, tobacco use, obesity with a BMI greater than 30, physical inactivity, a atherogenic diet, so just a horrible diet, and then those that may have metabolic syndrome, which is usually hypertension, hyperlipidemia, some glucose intolerance, as well as increased abdominal girth. Now, some of the non-modifiable risk factors, meaning, if you have one of these, you just do, and it's nothing you can do to change that particular risk factor. For instance, men over the age of 45, and then women over the age of 55. Men seem to have a higher risk than women. Family history, if you had a first degree relative that have gone, that has experienced any of these like risk factors, or had a coronary artery event that puts you at increased risk. Also, ethnicity. South Asian they have the highest risk. So what do you do to work up someone that you're suspecting to have coronary artery disease? So usually they're going to present with either shortness of breath, or they're going to present with this chest pain. So some of the key diagnostics would be you get some cardiac enzymes. So in the cardiac enzymes, you're looking for troponin I and T. That's usually the gold standard. You would also get an EKG or ECG. And on that, you're looking for any changes like in the T waves, any Q waves, or changes in the ST portion of it. And we'll discuss that a little bit later as well. And depending on your results from that, the next thing you would probably do is to do some stress testing, if they're able to walk and they meet the criteria. If not, you can always do like a left heart cath in angioplasty or angiography if needed. So acute coronary syndrome honestly is a spectrum, and it can be divided into like 4 different topics, one being stable angina, and that's stable chest pain, meaning they experience the symptoms of chest pain or shortness of breath with exertion, but it's relieved by rest. The next item is unstable angina, and it's the opposite. At rest, they still have some discomfort where they may have some shortness of breath. However, when you look at their EKG, it's not showing any significant changes. And if you look at their cardiac enzymes, they're negative. The third category is called a non-ST elevated MI, meaning they're coming in with symptoms. Their troponin is elevated, but there's no elevation in their ST segment of their ECG. And then the STEMI, which is the ST elevated MI, patient comes in with chest pain, shortness of breath. EKG or ECG shows ST elevations in certain leads, and then when you get a troponin back, it's positive. That kind of rules you in for acute coronary syndrome. That patient should go immediately to the cath lab. Okay, so this illustration was talking about, we finished up with coronary artery disease. Going to go ahead and switch gears and go over to heart failure. We're going to talk about 2 different types of heart failure. One is the systolic heart failure, which is a reduced EF, which is ejection fraction. Is usually less than 40%. Mechanism, the left ventricle cannot contract adequately, therefore you'll have a decreased cardiac output. This is seen in conditions such as MIs, dilated cardiomyopathy, myocarditis, and valvular disease. It can also be due or be affected by some neurohormonal issues, such as it can increase the renin angiotensin hormones. It can increase your sympathetic nervous system, which in return will increase preload and afterload, but will cause remodeling, meaning that left ventricle will start to remodel and likely develop hypertrophy. Some of the symptoms of systolic heart failure is dyspnea, orthopnea. They may also have a paroxysmal nocturnal dyspnea. Usually this is indicated that the patient has to sleep on like 3 or 4 pillows or more than 3 or 4 pillows at night. They can also complain of fatigue, and on exam you may hear a S3 gallop. Treatment will be, it's a combination, an ACE inhibitor or ARB, which will prevent remodeling. The beta blocker will help regulate their heart rate, because if the heart rate is increased, it may affect cardiac output as well. And ACE inhibitor, beta blocker, and a loop diuretic, something like aldosterone. And then there is an emergence of some of the GLT inhibitors that have shown to improve EF. So the next type of heart failure we're going to talk about is heart failure that has a preserved EF, meaning the EF ejection fraction is greater than 50%, equal to or greater than 50%. This mechanism is usually caused by a stiff, non-compliant left ventricle, and there's impaired filling, which will lead to increased left ventricular and diastolic pressure. Some of the causes can be hypertension, obesity, diabetes, aging, and hokum. The neurohormonal effect, increased filling pressures will lead to pulmonary congestion despite normal EF. Symptoms are similar. They will present with dyspnea, um, more so exertional than rest. Whereas with the systolic heart failure, they could actually have some of that dyspnea at rest. They can present with exercise intolerance as well as some peripheral edema. Treatment is diuretics, it's more symptom relief, and you need to control the blood pressure, heart rate, and volume. Again, the SGLT2 inhibitors have been proven to actually help a little bit with this EF. Now, some of the labs that you'll get on these patients to work them up, in the chemistry, you would get something called the BNP. The BNP is the brain natriuretic peptide. It is a hormone that is released by the heart ventricles when under pressure or high pressure or stress, often acting as a marker to diagnose or to monitor heart failure. Usually if it's over 100, there's heart failure likely. If it's over 300, I would recommend getting an echocardiogram on a patient, and that way you can actually, they can actually get a good or more specific number for the EF, a more accurate ejection fraction, and they can also monitor wall motion to make sure there's no abnormalities, because if the walls aren't moving as well, blood can be stagnant. That can actually lead to clots. You can also get a chest x-ray, and on a chest x-ray you may see cardiomegaly. You may also have these curly B lines. I wish I had put a slide in here, but it's basically these little curly lines, which are an indication of some increased volume that may also be shown on the x-ray in the lungs, which may be contributing to some of the patient's shortness of breath. You can also, during this workup, get a ECG, and you're looking for any left ventricular hypertrophy, and you're very concerned about any arrhythmias. Okay, this slide just gives an illustration, or it's a cartoon, but it's an illustration of what you would see. So systolic would be the reduced ejection fraction, can be due to a weakened left ventricle or a dilated left ventricle. There's less blood pumped out of the ventricles, and weakened heart muscle can't squeeze as well. Versus a diastolic heart failure, where you may have a stiffer ventricle, not necessarily weaker, but a stiffer ventricle. And you still have, less blood that is being filled within the ventricle. Okay, next, that's enough for the heart failure. Next, we're going to talk about some valvular heart disease. We'll talk about 4 different ones, and I'm going to talk about, I have some slides to where basically it's the same information. I'll talk about it separate because this slide is kind of busy, but we will discuss aortic stenosis, aortic regurgitation, mitral stenosis, and mitral regurgitation. So in aortic stenosis, this is usually, again, on the aortic valve, and this is a cartoon depiction. The aortic valve has 3 cusps, and with the stenosis, you usually start getting calcification on the different cups. So causes can be calcification that you see in elderly, but it can have a bicuspid valve, which is like a congenital abnormality in a younger patient. On exam, you can hear crescendo, decrescendo, systolic during systole. They can actually radiate up to their neck. Symptoms, they may present with syncope, angina, and dyspnea. So episodes of fainting, some chest pain, and then some shortness of breath. Key findings, their risk of surviving is decreased once symptoms appear. And treatment is usually surgical. Yes, treatment is usually surgical. It can be done, like the valve replacement can be done through a transcatheter aortic replacement, which is minimally invasive. It's a catheter-based procedure with faster recovery and fewer initial complications. Is now kind of the preferred, but if your patient can't tolerate it, you can go to the surgical aortic valve replacement. It is an open heart surgery. It's generally reserved for younger patients, those with, complex anatomy, low risk, or long-term durability need. Next, we're going to talk about the aortic regurgitation. Again, that is part of the aortic valve. A healthy aortic valve, when the blood is pumped from the left ventricle up through to the aorta, this valve will close and prevent blood from traveling backwards. Well, in aortic regurgitation, you actually see that, and some of the causes can be rheumatic fever, aortic root dilatation, endocarditis, and bicuspid aortic valve. Patients will have a murmur on exam. It's kind of high pitched, decrescendo, diastolic, so you can hear the murmur during their diastolic phase. These patients usually have a wide pulse pressure, and it's also known as the Austin Flint murmur. Symptoms, they can have exertional dyspnea, the water hammer pulse. Water hammer pulse is a physical exam finding characterized by a bounding, forceful, and abrupt rapid upstroke followed by a quick collapse, most commonly indicating severe aortic regurgitation. The next valvular heart disease we'll discuss is mitral stenosis. Cause of it is rheumatic fever. It's number one cause of it. Patients will present with a low pitch mid diastolic rumble. It's like an opening snap, very loud S1. When you hear it, you'll know it. Symptoms include dyspnea. They may present with a little atrial fib or hemoptysis. I'm sorry. Yes, symptoms may be hemoptysis, right-sided heart failure signs. Sometimes they can have something called a mitral phases, just a distinguished look. Treatment, you want to rate control with beta blocker, calcium channel blocker. Another treatment would also be PBMC, which is percutaneous mitral balloon valvuloplasty or mitral valve replacement. And the last valvular disease we're going to talk about is mitral regurgitation. This is usually caused by mitral valve prolapse, an MI to the papillary muscles, like an MI will cause the papillary muscles to rupture, or an annular dilatation. Patients will present with a holosystolic murmur at the apex that radiates to the axilla. Symptoms include dyspnea, fatigue, S3 gallop, left ventricular dilation from volume overload. Treatment includes an ACE inhibitor, diuretics, and valve repair or replacement. Okay, so next we're going to discuss hypertension, the classification mechanisms, and management. So first, we're going to talk a little bit about the pathophysiology. There's two types. You can have primary essential, which is about 95% of the population. It's usually due to genetics and lifestyle. Other than that, you can also have one that is due to the renin, angiotensin, aldosterone system, which can affect angiotensin 2 will cause vasoconstriction, and sodium and water retention via aldosterone, which can cause blood pressure to be increased. This can also be seen in renal artery stenosis. You can also have increase in sympathetic nervous system tone, which increases your heart rate and your systemic vascular resistance. That will also increase renin release, and that will in turn make the blood pressure elevated. So let's go through the classification. Normal is less than 120/80. If it's that, you just reassess annually. Elevated can be above from 120 to 129, still less than 80. If you have patients come in with that, recommendation is usually lifestyle modifications. The American College of Cardiology, along with the American Health Association in 2025, actually put out new recommendations. I left this in here because that's what I saw from the PANTS. However, the new recommendations is that aim for a blood pressure less than 130 and diastolic less than 80. But I'm going to go through these because this is what you're going to probably be tested on. If it changes before the PANTS, they will let you know. So stage 1 hypertension would be 130 to 139, diastolic rate between 80 and 89. This would be lifestyle changes plus or negative one drug. Usually you can do their acute syndrome usually do their 10-year risk stratification, trying to see if they're going to have some type of acute cardiac event. This is known as the atherosclerotic cardiovascular disease risk factor. Stage 2 would be greater than 140 for a systolic and greater than 90 for a diastolic. This is usually if you have patients that will come in, and this is like the second time they've come in, and their home readings may be something similar. You're going to educate them on lifestyle modifications, but you would place this patient on at least 2 drugs, preferably a diuretic, thiazide, and an ACE inhibitor or an ARB, plus a calcium channel blocker. Now, if you have a patient that shows up and their blood pressure is greater than 180 for systolic and greater than 120 for diastolic, but they don't have any end organ damage, you can place them on oral agents and lower over hours to days. This is known as a hypertensive urgency. No end organ damage, meaning you can't see where the blood pressure is starting to affect any other organ. Now, if they come in with that same blood pressure, but you do have end organ damage, meaning you notice arrhythmias, you notice encephalopathy or TIA, or you noticing some acute on chronic kidney disease, or if they're coming in with any type of eye symptoms, that's end organ damage. That's an emergency. You want to decrease their MAP, their mean arterial pressure, by 25% in the first hour. These patients are usually admitted, at least for observation, but they're usually admitted. So we've gone through pathophysiology, talked about some targeted organs that could potentially have damage. And then let's go through the first line pharmacology for the therapy. For African American patients, studies have come out stating that a diuretic, like a thiazide diuretic, as well as a calcium channel blocker, seems to work best. So a lot of times when I used to have patients, I would put them on that combo, but I would educate them on the side effects of the medicine. Calcium channel blocker can cause some swelling. I didn't see it often, but it can cause some swelling. You can also use the ACE inhibitor or an ARB. These are preferably for patients that have diabetes mellitus nephropathy. Studies have shown that it has a protective, the ACE and the ARB has a protective mechanism to it. Also, if a patient has a history of heart failure, you want to put them on the ACE and the ARB. Studies have shown that it reduces remodeling of that left ventricle. And if someone has had a recent MI, of course, you'll have them on the MI protocol, which will probably include ACE and ARB if they can tolerate it. So another option for hypertension treatment will be a calcium channel blocker like amlodipine. Seems to work better in elderly patients. Also, it can be a benefit for patients that have some form of angina. And again, like I said, for your African American patients. And lastly, another treatment for hypertension is beta blocker. If you have a patient that has a history of heart failure, then you want to have them on a beta blocker. If they've had a recent MI, you want them on a beta blocker. If they have a history of asthma or something like that, you have to educate them, and then you have to understand selective versus non-selective beta blocker. because some beta blockers are just specific to the heart, some may be the heart and the lungs. Okay, that finishes up hypertension. Next, we're going to go to cardiac arrhythmias. This is topic 4. We'll talk about the mechanisms, type, complications, and management. And all of this correlates with Module J, Instructional Learning Objectives 2 and 5. Okay, so this next area we will be talking about arrhythmias, but before you get into arrhythmias, just want to do a quick review over an ECG or EKG, the waveform, and just discuss a little bit about what each part represents. So in the EKG, you're looking for P wave, Q wave, RS, and a T. So the P wave represents atrial depolarization. This starts in the atrium. It's from the SA node. The SA node fires the electrical activity of both atria. Happens, and this leads to contraction. So it causes the atrium, the top part of the heart, to contract. That electrical pulse is reflected through the P wave. Next, you have the PR interval. This is due to AV node delay. So you have the contraction, the electrical impulse. It goes from the SA node down to the AV node. The AV node will cause the conduction to pause. This allows for the ventricle to fill with blood. That's reflected through the PR portion of your complex. Next, you will have the QRS complex. This represents ventricular depolarization. So you end up having the electrical impulse that it was paused at the AV node to allow the ventricle to fill. Now the ventricle is ready to contract, and this impulse goes between the two ventricles, and this initiates the contraction of the ventricles. So you'll have, the atrium and the ventricle. The atrium contracts, there's a pause, ventricle fills up, and then it contracts. And that's the 1 beat, second beat. Again, that is reflected in your QRS, and that indicates ventricular depolarization. Next on your ECG is your ST portion. This is where you have early repolarization of the ventricles. The ventricles are fully depolarized, no net electrical movement. The ST elevation and depression would normally signal ischemia. Then with the T waves, the ventricle begins to repolarize. So the ventricles return to rest, to its resting electrical state, and it sets up for the next cycle. So then that goes all the way around and it starts back over. And that's how you get your complex for the ECG. And before we start going through some abnormal ECGs or the arrhythmias, just want to briefly go over how you can come up with a systemic approach to interpretation. So when you have an ECG finding, one of the first things you want to do is identify the rate. The rate can be the number of boxes between the two R complexes. You can count the R's and multiply it by 10 if it's a 6-second strip, or you can use the big boxes. Like I will try to find an R on one of the lines and then count and divide it by 300 to get the rate. But the normal rate is usually between 60 and 100 beats per minute. Next, you want to identify the rhythm. So if you calculate R, is the rhythm the same? Are the R complexes spaced identically? So regular RR intervals is a normal rhythm. Irregular RR rhythms can show some form of arrhythmia. The next thing I usually do is I identify the P wave just to make sure they have P waves. If they're a P wave and they are uniform, that's usually normal sinus rhythm. So P wave R intervals are all the same, that's normal sinus rhythm. If it's between 60 and 100, you can have it less than 60 with P waves and the RR interval being normal, but that could mean bradycardia. If there's no P wave or it's not uniform, that's usually an indication of either atrial fib or atrial flutter. The next step is to determine the PR interval. So any PR interval that's greater than 0.2 seconds usually indicates a heart block, because the normal PR interval is 0.12 to 0.2. And then the fifth thing I normally do is to check for the QRX complex to see if it's widened or narrow. Normal is 0.08 to 0.12 seconds. If it's widened, you usually think about PVCs, any type of bundle branch blocks. Sometimes you can think about drug toxicity as well as some electrolyte imbalances. If it's narrow, you always think about Wolff-Parkinson-White syndrome. So here is a normal rhythm strip. The R's look to be about the same. You have a P wave in front. The PR interval is normal. QRS interval is normal range. There's no ST elevation. So let's talk about when we see things that are abnormal. And we'll start off with atrial fibrillation. The definition of atrial fibrillation is disorganized atrial activity. You have pretty much a chaotic atrial firing, and there's a loss of coordinated contraction. So your atrium and your ventricle are contracting not in sync. You have a irregular ventricular response. There's no predictability in the R to R intervals, and there's no distinct P waves. This puts patients at risk for thromboembolisms, because if there's no coordinated contraction, you can have kind of stasis in the left atrium, which can throw a clot. So if the blood is just sitting there, it can potentially clot, and then you can throw a clot, and patients are increased for risk. So clinical features and ECG findings, again, you have a irregular rhythm, absence of a P wave, and variable ventricular response. Symptoms may include palpitations, fatigue, dyspnea, possible syncope, and chest discomfort. Complications, Again, thromboembolisms. These patients are at 5 times increased risk to have a stroke. They're also increased risk for heart failure exacerbation. Treatment would be rate control. So you can do it with a beta blocker. You can do it with a calcium channel blocker. Sometimes you can rhythm control them. So if it's very irregular rhythm, they can be rate controlled. And then sometimes you may need ablation for definitive therapy, where they go in, they just burn the little node, the little area that is overfiring. And this is what the rhythm strip looks like. It is no rhyme or reason. You can see the distance between this R and R and this one is not the same. You can't distinguish any P waves. So irregular rhythm, no distinct P waves, and absence of organized atrial activity. And so the counterpart to atrial fibrillation is atrial flutter. It is due to micro reentrant circuit within the right atrium. The rate can be 250 to 350 beats per minute. It's very rapid atrial firing, often with a fixed AV block. You usually see on the EEG like classic sawtooth patterns in the inferior leads, which will be 2, 3, and ABF. EKG findings, you have regular atrial activity with sawtooth flutter waves. Ventricular rate depends on the AV conduction ratio. And I'll show you what all that means. Common causes can be coronary artery disease, COPD, post-cardiac surgery, and structural heart disease. I've also seen it with some of the cardiac meds as well. Complications. Again, it's very similar to atrial fib. You can have a thromboembolism and also end up with a cardiomyopathy that's due to a tachycardia-mediated treatment, very similar to atrial fibrillation, beta blocker, calcium channel blocker, rhythm control, or ablation for definitive therapy. And so you see it's a rapid atrial rate. Based on this, it's about 150. And have a sawtooth flutter wave pattern and variable AV conduction. Next, we're going to talk about SVT, so supraventricular tachycardia. This is also known as rapid narrow complex tachycardia. The heart rate is usually above 150. It originates above the ventricle, usually at the point of the AV node reentry. The AV node reentry tachycardia is the most common type. There's a dual pathway of reentry circuit within the AV node. It can have a sudden onset and termination, so meaning SVT can start and stop. So it can have a paroxysmal effect to it. A lot of times, because it's going so fast, the P waves are often hidden. So you may have a retrograde P wave that may be buried in or just after the QRS. So some of the ECG hallmark findings is regular with a rapid rhythm and a narrow complex. P waves are absent or inverted or retrograde. Symptoms include palpitations, lightheadedness, chest discomfort, may be triggered by caffeine, stress, or exertion. Management can include vagal maneuvers as first line, adenosine for termination, can be diagnostic and therapeutic. The adenosine will also give you the underlying rhythm. Sometimes, what I mean by that, I've had patients that have SVT. I gave them adenosine, and then it showed like a 2-to-1 atrial flutter or a 3-to-1 atrial flutter. Rate can be controlled with a beta blocker or calcium channel blocker, and ablation for recurrent AV node reentry tachycardia. So again, you're going to have narrow complexes. So the QRS is narrow, rapid heartbeat. This is probably around 150, and P waves are often hidden. You can't really see the P waves unless it's hidden in between here. Next is ventricular tachycardia. This is your wide complex arrhythmia, tachyarrhythmia. Rate is typically above 100 beats per minute. It can originate in the ventricles below the AV node, whereas the other originated above the AV node. There's two types, monomorphic versus polymorphic. Monomorphic, you have uniform QRX morphology, meaning the QRX looks pretty much the same. And then the polymorphic is a variable QRX, and you usually see this in torsades, usually with a patient that has like low magnesium, or someone that has a form of toxicity that has caused like a prolonged QT interval. They can turn into a torsades. There's usually AV dissociation, meaning P waves march independently from the QRS. Fusion beats and captured beats may be present. This is life-threatening, can rapidly deteriorate into ventricular fibrillation. So hallmark again for the ECG, wide QRS, which is usually above 100 or 120, rapid regular rhythm. There's some AV dissociation. Common causes include prior MI or some type of ischemic cardiomyopathy, dilated or hypertrophic cardiomyopathy. Again, electrolyte disturbances like hypokalemia or hypomag. Also drug toxicity like digoxin. Complications include hemodynamic collapse, and it can progress to ventricular fibrillation. Management, you want to give this patient something to stabilize the VTach. Amiodarone is a good drug. You can have procainamide and lidocaine. If they are unstable with the pulse, you're going to do synchronized cardioversion, so you will shock them. And if they're pulseless, then you're going to defibrillate, which is the unsynchronized, and resume your CPR. I would consider a ICD for long-term prevention, meaning the ICD will do the cardioversion for them. And this is what the rhythm strip would look like. You have a wide QRS complex, you have a fast heart rate, and then there is arterioventricular dissociation. Next, we're going to talk about ventricular fibrillation. This is chaotic, disorganized electrical activity. The ventricles basically quiver instead of contracting. There's no effective cardiac output, and this usually leads to immediate hemodynamic collapse. If patients are pulseless, this is usually a lethal rhythm, and it's the most common cause of sudden cardiac death. So your ECG findings, again, completely chaotic waveforms, no identifiable P waves, the QRS complexes, or T waves, irregular amplitude and frequency. Clinical presentation, patients usually present unresponsive or pulseless, and they may have some agonal respirations or apnea. Immediate management is defibrillation first. It's the first and only effective therapy, and you have to resume high quality CPR, trying to make sure that you still have blood circulating throughout to get to the brain and the heart, and then you can do epinephrine every 3 to 5 minutes. And this is the rhythm. It's just chaotic, irregular. So just a comparison between the two, ventricular tachycardia is a wide complex tachyarrhythmia. It is organized and you may have a pulse versus ventricular fibrillation is not organized, no pulse. They're always pulseless and it requires immediate defibrillation. Um, Also going to talk a little bit about heart block because you guys will see this. Um, we'll probably touch on this as the curriculum progresses, but I just want you to know the one that is the red flag that you want to make sure that you have identified. So third degree heart block is complete failure of AV conduction. No electrical impulses from the atria reach the ventricle. The atria and the ventricle activity becomes dissociated, meaning they're just beating on their own, out of sync, with no signal from the other. Each follow its own intrinsic pacemaker. There are independent heart rates, so the atrial rate typically normal, while the ventricular rate is usually slow or junctional rhythm. This is life-threatening, can lead to syncope, hypotension, and sudden cardiac arrest. The ECG hallmark findings. P waves march through at a constant rate. The QRS complexes march independently. There's no relationship between the P waves or the QRSs. The ventricular escape rhythm, which is known as a junctional rhythm, does have a narrow QRX. And if it's a ventricular rhythm, it can also either have a narrow QRX or a wide QRX. Symptoms include fatigue, dizziness, syncope, hypotension, and bradycardia. Management, you need immediate stabilization if they're unstable. Atropine often is ineffective. These people need a transcutaneous pacer until they can get a pacer, but a permanent pacemaker is the definitive treatment. And this is what the rhythm strip looks like. Like, yeah, you don't see any association between the P waves and the QRSs. And lastly, a long QT syndrome or prolonged QT interval. You can have the QT interval that's greater than 440 in men and 460 in women. This can be congenital or acquired. Congenital can usually be due to some form of genetics, and these are genetic markers that are abnormal. Acquired is normally due to medications like anti-arrhythmics, microlids, which is antibiotics, antipsychotics like digoxin can cause this, but also electrolyte abnormalities. You'll see this probably with patients that may have hypokalemia, hypomag, or hypocalcemia. You worry about the risk of this going into a polymorphic ventricular tachycardia, which is basically torsades. This can quickly develop to VFib, which can be catastrophic. So the ECG findings, you have a prolonged QT interval, broad extended repolarization phase, and possible T-wave abnormalities. They may be notched or low amplitude. Symptoms include palpitation, syncope, especially with exertion or startle, or if they're startled. You can have seizure-like episodes from cerebral hypoperfusion. Management can include remove the offending drug, correct the electrolytes, which is mainly magnesium. You can also use a beta blocker if it's something congenital, and consider an ICD for high-risk cases in case they do go into that VFib and they need to be shocked. And this is what it looks like. So the Q to T, very long. Delayed ventricular repolarization, you put it increased risk for polymorphic ventricular tachycardia. This is a very busy slide. Basically, I put everything from the last few slides on one slide. So it just gives you a rundown if you want to compare them side by side. It also talked about the key complications and then treatment. Okay, next I'm going to talk about topic 5, which is atherosclerosis. We talked about it a little bit earlier. I'm going to be brief in it in this section, but I will recap on the pathogenesis, but I'll end up talking about coronary and mainly peripheral vascular disease is due to the atherosclerosis. If you're following your syllabus, this is Module K, Instruction Learning Objective 4. So kind of went over this earlier, this part of the endothelial injury. So you have an injury or dysfunction that can be caused by tobacco use, hyperglycemia, dyslipidemia. This will increase permeability and also increase adhesion molecules. So you have these adhesion molecules that are circulating around. If you have increased LDL that infiltrates and causes oxidation, the LDL enters the subendothelial space. It oxidizes, which causes these molecules to attract to it, and then it triggers an inflammatory cascade. These form what is known as foam cells, which are monocytes and phagocytes that have ingested the oxidized LDL. These can lead to fatty streaks in the vessel, and that's usually the earliest visible lesion. This will These foam cells will migrate to the smooth muscle and they will attach to the smooth muscle, and this forms the fibrous cap. What happens that causes the atherosclerosis to progress to a stroke or acute coronary syndrome, you have a rupture in that plaque. So the thin fibrous cap plus a large lipid core is a very vulnerable plaque. If there's any type of degradation of that plaque, it can rupture. And once it ruptures, you have platelet aggregation to that site where it ruptured, and then a thrombus is formed. So the clinical manifestations by vascular territory include a coronary, you'll have stable angina, non-ST elevating MI, ST elevating MI, cardiac, sudden cardiac death, I'm sorry, or cerebral vascular, you can have a TIA, which is usually reversible in the first 24 hours. You can have ischemic stroke. You can also have carotid artery disease or vascular dementia based on this. You can have peripheral vascular disease, which usually presents with a claudication, which is pain in the legs on rest. You could have actually some limb ischemia, and they may present with some non-healing ulcers. And also with this, you can have some renal artery stenosis, renal vascular hypertension, and some ischemic nephropathy that leads to chronic kidney disease. And this is a little cartoon that's showing the endothelial cell layer. You got the LDH is coming in. It's going to come in. You're going to have an inflammatory response. The monocytes and macrophages will eat it, turn into a foam cell. The foam cell attaches. Something happens to where there is a rupture. Once it ruptures, you have a secondary inflammatory response where platelets will aggregate, forming a clot. This is also another picture of it. So you have LDL coming in, you have the anti-inflammatory macrophages. They come in, they ingest the LDL, you see it? So that's the macrophages that have eaten the LDL, turns into a foam cell. Foam cells migrate, they line lining of the endothelial lining in the vessel. Something happens, you have a disturbance in the structure, it ruptures, the plaque ruptures, and it causes for platelets to aggregate, and then you have a clot that's going to form. Okay, so that's going to conclude the atherosclerotic topic. Next, I'm going to go to topic 6, which is the thrombotic and embolic disorders. Going to talk about mainly DVTs and pulmonary embolisms. I'm going to talk about diagnosis and management. So next, we're going to talk about DVTs and PEs, go through a little bit of the pathophysiology, the diagnosis and the management. So initially, when you're thinking about a DVT, there is a triad, Virchow's triad, which includes venous stasis, endothelial injury, as well as hypercoagulability. So with venous stasis is usually prolonged immobility, surgery that happens sometimes after surgery, post-op, long flights, paralysis, or you can see it sometimes in atrial fib. Endothelial injury can be seen in trauma, surgery, central lines, or if they have a history of prior DVTs, also infection and inflammation. And then the hypercoag possibility is usually due to like factor V, Leiden can be protein CNS deficiency, prothrombin mutation, malignancy, pregnancy, oral contraceptive pills, so birth control pills can do it, and then those that may have antiphospholipid syndrome. With the DVT, clinically, they may present with calf pain, swelling, warmth, erythema. A lot of this can be determined as a Homan sign, which is can be low sensitivity. And just for clarity, Homan sign is a physical examination maneuver that historically has been used to check for a DVT in the leg. Can be indicated by pain in the calf or behind the knee when the foot is passively dorsiflexed or flexed towards the shin. Again, it's low. It has a low sensitivity. What people normally use is the Wells DVT score, and if it's greater than 2, it's a high probability, which should prompt you as the clinician to order a ultrasound for further evaluation. And so the counterpart to DVT is usually a PE. So the pathophysiology of a PE, DVT is usually proximal in the proximal leg or pelvis, will embolize to the pulmonary artery. You'll have increased pulmonary vascular resistance, right ventricle pressure overload can cause acute cor pulmonale, which can lead to decreased left ventricle preload and decreased cardiac output. A lot of times, you notice to have a VQ mismatch with hypoxia. I will discuss this a little bit more detail next week when we go through our pulmonary lecture. So some clinical features, there is a classic triad, but only 30% of the patients present with the triad. They can have pleuritic chest pain, dyspnea, and hemoptysis. But more commonly, you'll see tachycardia or tachypnea, so increase in their respirations. You may also notice that their O2 sats is a little bit lower. They can present with syncope. A lot of them will already have signs that they have a DVT. If there is a massive PE where it is taking up most of the pulmonary vasculature, the patient will present with hypotension. They can also present with an obstructive shock, and I'll talk about the obstructive shock a little bit later. Diagnostic, again, you can use the Wells PE score. And the Wells score is basically just a clinical tool used to estimate the probability that a patient has a blood clot in their lungs. It's a calculation that's normally performed by medical professionals based on the patient's current symptoms and history, and the patient will receive points for each clinical feature. If the score is greater than 4, a P is likely. So for the DVT, if the score is greater than 2, it's high probability. For a PE, if the score is greater than 4, it's a high probability. When I came through training, we did a lot of D-dimers, but D-dimers can actually be elevated due to like acute phase reaction, infection, just anything can elevate it. So it's very sensitive, but not very specific. But The gold standard for diagnosing it is a CT pulmonary angiogram. A VQ scan can be helpful if, for whatever reason, the contrast from the CT pulmonary angiogram is contraindicated. Also, you would need to get an echocardiogram to determine right ventricular dilatation. Your ECG will probably show tachycardia. So management is usually with anticoagulation, and there's so many out is preferred. You can also do low molecular weight heparin to bridge to warfarin if needed. Treatment, if this is the first time, is 3 to 6 months. Massive PE with hemodynamically instability. You may need to give systemic thrombolytics, such as TPA. Also, I would get surgery on board because a lot of times the surgeons can go in and do an embolectomy. When I came through training, we put IVC filters in everyone. Studies came out and said that they actually can increase your risk for a clot. However, I do think it's pertinent if patients have had recurrent clots and if anticoagulation is contraindicated. So on this picture, it just shows normal blood flow. This is DVT, normal blood flow. And then you had an injury some type of way and the thrombus is starting to form. And then it turns into a deep vein thrombosis. And then part of it breaks off. The embolus or emboli will break off, travel up through the inferior vena cava, and then pieces of it will get lodged in the lungs. So you have pieces of it in the lungs. And that concludes PEs, DVTs. Next, we're going to talk about shock. It's the 7th topic. It correlates with Module K, Instructional Learning Objective 6. We're going to discuss hypovolemic, distributive, cardiogenic, and obstructive shock. I showed you this slide earlier. This is where we'll talk a little bit more about the systemic vascular resistance, the pulmonary capillary wedge pressure, and the central venous pressure, because all of these things can affect stroke volume, and these things are very important in shock. So let's talk about the mechanisms, hemodynamics, and the management. I'll start off with hypovolemic shock. This is usually due to a loss of intravascular volume, such as hemorrhaging, dehydration. You can see this in burn patients. There is a decreased preload because the volume is low, which in turn decreases the stroke volume, and therefore your cardiac output will also be decreased. Hemodynamics, you have a decreased cardio output, you will have an increased systemic vascular resistance and a decreased pulmonary capillary wedge pressure. Clinical signs will show tachycardia, cool and clammy skin, and flat neck veins. Treatment is IV fluids for resuscitation, blood products if possible, and to control the source of loss. Clinical examples include trauma-related hemorrhage, like someone in a MVA. May have rapid blood loss that leads to decreased preload and hypotension. Another clinical symptom was like severe gastrointestinal bleed. from like a duodenal ulcer that may have been perforated. And then the third one could be profound dehydration, from like nausea, vomiting. Norovirus can do this, cholera can do it. Giardia, not so much, but norovirus can do it. Next, we're going to talk about distributive shock. This is usually due to sepsis. It can also be due to anaphylaxis or some form of neurogenic shock. You have massive vasodilation, which will cause decreased systemic vascular resistance, and that's how you get a relative hypovolemia. So with your hemodynamics, you have increased or normal cardiac output, but you have decreased SVR and decreased PCWP. Clinical signs: warm, flesh skin, early, bounding pulses, then fever. Treatment: norepinephrine is the first line, fluids, and then treat the underlying cause. Clinical examples include septic shock, anaphylaxis, and neurogenic shock. The next one we'll talk about is cardiogenic shock, or what is also known as pump failure. This is usually due to a MI. It can be due to acute heart failure, myocarditis, or severe valve failure, but I've seen it most commonly in a severe MI. The pathophysiology: you have decreased contractibility, which leads to decreased cardiac output. You'll have a compensatory increase in the systemic vascular resistance, which worsens the failure. So the hemodynamics: you have a decreased cardiac output, increased SVR, and increased PCWP if you're monitoring in the unit. Clinical signs include pulmonary edema, JVD, or jugular venous distension. You may also hear a S3. The patient is cold and clammy. Treatment: norepinephrine, dobutamine. If they have had an MI, they need to go to the cath lab for percutaneous intervention. But you also want to avoid volume overload because they're already starting to show some signs of pulmonary edema. Clinical examples include large anterior STMI, decompensated heart failure with reduced EF, and acute severe mitral regurgitation. And the last shock that I want to talk about is obstructive shock. This is a mechanical obstruction to the flow. Causes can be a PE, like we said earlier, can be a tension pneumothorax or cardiac tamponade. I've seen it with a PE and cardiac tamponade. Pathophysiology: there's a physical obstruction that's going to lead to the decreased ventricular filling and outflow. Therefore, it's going to lead to decreased cardiac output. Hemodynamics: you have decreased output, which leads to an increase SVR, and your pulmonary capillary wedge pressure varies. In tamponade, is increased, but in a pneumothorax, is decreased. Clinical signs could be tamponade. Tension pneumothorax may be absent breath sounds, tracheal deviation, and a PE, of course, you would have the dyspnea, chest pain, hypoxia. Treatment: you want to relieve the obstruction, thrombolytics, embolectomy, needle decompression, for attention pneumothorax and pericardiocentesis if they have tamponade. And those are some of the clinical examples. And this is just a cartoon that's illustrating hypovolemic shock, hemorrhage, dehydration, volume loss, cardiogenic, usually due to MI or heart failure. The muscle is damaged, pump can't meet the demands, so pump failure. Distributive shock is vasodilation. You have decreased systemic vascular resistance. This is usually due to sepsis, anaphylaxis, or neurogenic. And then you have obstructive, where you actually have something that's blocking. You see you have a clot there, you may have tamponade there. So there's a mechanical obstruction. And this is just a summary slide that is saying the same thing from the previous two slides. So topic 8 will be on the peripheral vascular disorders. This correlates to Module K, Instructional Learning Objective 8, 9, and 11. So we're going to talk about peripheral arterial disease. The pathophysiology of this is usually due to atherosclerosis. You have a narrowing of the peripheral arteries, most commonly in the lower extremities. Risk factors include diabetes, smoking, hypertension, hyperlipidemia, chronic kidney disease. Symptoms include intermediate claudication. Claudication is when you have pain with exertion that is relieved by rest. You can have critical limb ischemia, pain, pallor, pulselessness, paresthesias, paralysis, and polar. If you have those, it's usually an emergency. Diagnosis, if you have a patient that you suspect of this, you will order ABIs, which is ankle brachial index. They're going to check the pulse, pressure and pulse in their ankle and the brachial area and compare the number. If the result is less than or equal to 0.9, that's significant with peripheral arterial disease. If it's less than 0.4, that's critical ischemia. You can also do Dopplers, CTAs, and angiography. Treatment is usually supervised exercise, but you do have some medications that can help: aspirin, statins, lelostazole, and blood pressure control. Revascularization can also be a treatment where they do percutaneous angiography and stenting or bypass surgery. Unfortunately, if it continues to progress, especially if they have wounds that are not healing, you may have to amputate. Next, we're going to talk about chronic venous insufficiency. This is usually due to incompetent venous valves that can lead to venous hypertension. And then you have the capillaries to leak, and then it can cause edema. It usually presents with edema, varicose veins, and then some hyperpigmentation. This hyperpigmentation is usually due to hemosiderin that leaks out. This can also lead to some ulcers, so venous stasis ulcers of note. Those ulcers are usually on the medial malleus or malleolus, whereas with peripheral vascular disease, they're on the lateral side. The ulcers are usually shallow and painless. Treatment for this is to get them into compression stockings, usually 20 to 30 millimeters of mercury, keep the legs elevated, wound care. They can do some sclerotherapy or ablations of the varicose veins if needed. And the last vascular disease we're going to talk about will be aortic aneurysm and aortic dissection. So with an aortic aneurysm, the infrarenal aorta is the most common area. Risk factors include being a male, smoker, hypertension, and greater than the age of 65. If they're symptomatic, it can be a pulseless abdominal mass felt in the back or the flank. If it ruptures, they will feel like a tearing sensation in their abdomen, and that can lead to hemorrhagic shock. Screening has started to where you get one abdominal ultrasound if a man is between the ages of 65 and 75 who has a history of smoking. Repair includes endovascular aneurysm repair, which is a minimally invasive catheter-based procedure used to treat abdominal aortic aneurysms, or open surgery if it's greater than 5.5 centimeters or rapidly expanding. So the aneurysm is here. Can also have an aortic dissection. Kind of looks like an aneurysm from the picture. However, there is a intimal tear and blood will enter the media. So through here you can see, and then there's a little small tear and blood starts to enter and it forms what looks like ends up looking like an aneurysm. If it is ascending, so like this was ascending in the aorta, that's a surgical emergency. If it's descending, you can do medical management with IV beta blockers. If there is a sudden tearing, ripping pain, that's usually how they present and it radiates the back. Also, if it's in the ascending aorta, do blood pressures in both arms because there will be a discrepancy. Diagnosis, the gold standard is a CTA of the chest. So on topic 9, which are risk factors and prevention from cardiovascular disorders, this correlates to Module K, Instructional Learning Objective 7. So let's talk a little bit about cardiovascular risk factors and atherosclerotic cardiovascular disease stratification and prevention strategies. So the American College of Cardiology and the American Heart Association, they have this atherosclerotic cardiovascular disease 10-year risk stratification that will put you in low risk, borderline, intermediate, or high risk based on different numbers. So it's a formula that usually includes your lipid profile, your BMI, your blood pressure. So if a patient is seen to be low risk, they just need to have lifestyle modifications only. Those lifestyle modifications can include a Mediterranean or DASH diet, doing 150 minutes per week moderate aerobic exercise, smoking cessation, limit their alcohol to less than 2 or less drinks a day, weight reduction by 5 to 10%, and decrease their blood pressure, lipids, and glucose. Borderline is if their risk factor is between 5 and 7.4%. You want to risk enhancing factors to guide statin decision. You want to get better metabolic control. So you want their hypertension target to be less than 130/80. You want their LDL to be better controlled if it's high. You want the hemoglobin A1C to be less than 7. Now guidelines for hemoglobin A1C is less than 5.6. You may consider putting them on a SGLT2 or GLP-1 for cardiovascular benefits. If they are obese, you want them to get their BMI less than 25 and their waist circumference less than 40 inches for males and less than 35 inches for females. If they have chronic kidney disease, they are at increased risk. So you have to be a little bit more aggressive with their blood pressure and lipid control. Intermediate risk is from 7.5 to 19.9. This is considered moderate to high intensity statin and aspirin for their treatment. You want to consider that. The approach would be structural and pharmacological. So an aspirin, but only if their risk is greater than 10% and the bleeding risk is low. Consider putting them on an ACE or ARB, especially if they have heart failure, diabetes, or post-MI. Also consider putting them on a beta blocker, especially if they've had a post-MI, heart failure, or arrhythmia. And if they have anything like atrial fibrillation, they need to be on anticoagulation. And the highest risk is those that score greater than 20%. You want to do high intensity statins for them, and aspirin, and pretty aggressive risk factor control. So you want to make sure the risk factors are aggressively controlled. Other things that you should consider, you have to be aware of these patients when it comes to any type of infections that may compromise their cardiac status. So for example, flu and COVID vaccines, you want to decrease any cardiovascular events. If they're having dental issues, you want to decrease any endocarditis risk. Periodontal disease is linked to increased atherosclerosis. You want to give them prophylaxis for any rheumatic fever, and you want to screen them for obstructive sleep apnea, because if it's left untreated, it can increase hypertension, could lead to atrial fibrillation, and can lead to sudden death. Okay, this is going to be the last portion of the combined modules. I'm going to talk about some high yield cardiovascular infections with endocarditis, myocarditis, and pericarditis. And this correlates to Module K, the instructional learning objectives 12 through 18. So this is a very busy slide, very, very busy slide, but all important stuff. So let's talk about infectious endocarditis. Risk factors of infectious endocarditis is usually IV drug use or prosthetic valve, history of intravascular line or poor dentition. The organisms include Staph aureus, Staph viridans, Enterococcus, Staph bovis, and fungi if they're immune compromised. Manifestations: fever and a new regurgitant murmur. They may also have oscillatory nodes that are painful on the palms and their fingernails. You can see the Janeway lesions as well. They could also have the raw spots, what looks like little splinters on their nails. I'm going to check them for splenomegaly and, look for any signs of septic emboli. So if they have an abscess somewhere, it may have seeded. If they have any changes in their neural status, you want to make sure they hadn't thrown a clot and have had some type of TIA or stroke. The Duke's criteria for this, identifying the infectious endocarditis, they have to have 2 or more positive blood cultures, evidence on an echocardiogram, which is usually a vegetation or abscess, diagnostics, should obtain 3 blood culture sets before antibiotics, get an echocardiogram, a TEE, so a transesophageal echocardiogram is more sensitive than a transthoracic. Get an ECG, making sure they don't have any PR prolongation, which may indicate a perivalvular abscess. Treatment: if it's a native valve, you can cover for MSSA with nafcillin, oxacillin for 6 weeks. If it's a prosthetic valve, you want to treat for MRSA, or if they've recently been in the hospital, so you can do vancomycin and rifampin. If it's strep viridans, I'm sorry, I said staph viridans earlier, I meant strep viridans, you should treat with the penicillin as well as gentamicin. And the only time you do surgeries, say if it's on a heart valve and you need to replace the valve, is when they're decompensating and it's persistent bacteremia, they're not clearing it, and or if the vegetation or the abscess is extremely large, because it can lead to decompensation in other places and lead to heart failure. So that's the take home on infectious endocarditis. Next, we're going to talk about myocarditis. It usually presents in a young patient with chest pain, dyspnea, new onset heart failure with palpitations, and it's usually followed by viral prodrome. Diagnosis could be increased troponin, echocardiogram shows decreased EF, cardiac MRI is the gold standard. And sometimes you can do an endomyocardial biopsy. It can be due to the Coxsackie virus, and or it can be due to certain drugs as well. Treatment is supportive. Avoid NSAIDs. Manage if they have heart failure symptoms. Place ICD if the EF stays lower than normal. You can't give them IVIG if they're not improving too. And lastly, you're going to talk about pericarditis. It's the one I see most often. Actually, pericarditis and endocarditis I saw pretty frequently. Pericarditis can be due to a viral. You can have Coxsackie as well. It could happen after MI. It could be autoimmune. I've seen it in lupus. I haven't seen it much in TB, but I've read about it. So it can be in any of those. They usually present with sharp pleuritic chest pain that increases when they are supine, they lay back, but when they lean forward, the pain decreases. When you're listening to them, this is pathopneumonic. You can actually hear a pericardial rub. What a rub sounds like to me is like Velcro. It's almost like you hear a Velcro that's synced with the beat. Diagnosis, you will have a ECG, which show diffuse ST elevation pretty much in all the leads with a saddle shape. You can also see PR depression. You would order echocardiogram. A lot of times they can do it right at the bedside, especially in the ED. You can see the infusion, or you can also order feed rate and a C-reactive protein. Treatment for the pericarditis that's viral is with NSAIDs and colchicine, and you'll use steroids if it's refractory. If they're showing signs of tamponade, which you may see on the ECG, which classically on the ECG you will see sinus tachycardia, a low QRS voltage, and electric alternans. If you see that, then they would need a cardiocentesis. Okay, this last slide is just some very high yield pants pearls that I do want you guys to remember and just, go through. These are some of the highlights of this lecture as well, but there are also things that you will likely see on your exam as well as your pants. So it's kind of like your review slide. And these are just some references from this lecture. It's going to be very important moving forward that you guys rely on some of your texts. Current is really good and has really good information, but your pathophysiology of disease is another good one that I would recommend that you have as a resource. Because the lectures are going to start to become really heavy. To me, that was a really heavy lecture. That's why I wanted to combine them so that it wouldn't be too redundant. I probably still will work on a study guide for you guys, but I just need to think about what's the best approach at presenting it. I've done clinical vignettes a couple of times, and I want to see if there's a different approach that may help you guys to retain this information, because I do think with this last test it will probably be less recall or understanding. It's going to probably be a little bit more apply and analyze. But we'll see moving forward. Thank you for your time. And if you have any questions or concerns, please feel free to email me.